Thanks everyone for coming today. So today is the second day of this seminar cycle with Professor Libertario Demi. For those of you who don't know him because they were not here yesterday, he's a professor visiting from the University of Trento in Italy, and he's a world expert in lung ultrasound. So without any further ado, the floor is yours.
Thank you. So before we move to the second lecture, I would like to finish the first. And so we arrived yesterday discussing some of the aggregation techniques, so to obtain a video level assessment of the data starting from frame level assessments. So in here, I'll show you results of a technique that basically starts from this idea. So if you want to score every frame in your video, then it means that you have to perform a certain level of operations, and that is repeated n times, with n being the number of frames. We have 300 frames, so that can be costly. The idea here is, why not instead we compress the video essentially to a single image, and then we make the decision on that image. And the idea is whether we can find a compression method so that image is in fact representative for the information in the video. So the idea here is to compress based on intensity levels, and what we basically did is compression based on the maximum intensity found in the pixel, with the idea that artifacts, at least vertical artifacts, and the anatomical landmark or the pleural line have high intensities. So you can do this maximum intensity projection to identify those type of patterns in the video. On the other hand, consolidations are hypoechoic regions. So in that case, we opted for a minimum intensity projection. And so the idea is then to compress a video in the max, mean in the sense of minimum, and mean in the sense of the mean intensity projection. So for every video, we have 3 frames only instead of, say, 300. And this is the result when we then apply the methods we developed and we saw before for frame level classification and apply them directly to these compressed data. And you see the performance when you look at the prognostic assessment, which are the bottom confusion metrics. You see values are above 80%, and this allows for a strong reduction of the computational load. So with this being said, another thing I would like just to touch on is the generalizability and problem of data scarcity, because sometimes in certain contexts you may not have a lot of data. So is it possible, in fact, to generalize, for example, solutions we developed, as you saw, for adults, patients affected by COVID-19, and move them and apply them in other contexts? We did some tests. One, which I'm showing here, is a collaboration with Boston University, where we used our models to essentially detect the presence of consolidations in data acquired with ultra-portable device. In this case, it was a butterfly. And the population is a pediatric population in Africa, right? So it's a low resource setting, and there we successfully applied the algorithms we developed for adults in this population. Of course, you can apply it as they are, or try to essentially tune it and fine-tune essentially then the solution with a bit of retraining on the new data. That of course improves the performance. And what's interesting actually to see at the bottom plots on the right, where you see age population versus essentially the accuracy, you see that if you don't fine-tune, what you actually have is that the higher the age of the patient, the higher the performance, because that means it's moving closer to an adult's condition, while the younger is the patient and the worse is the performing. While after the tuning, you kind of balance this out. And this was particularly interesting because we had a lot of data with adults, but we didn't have a lot of data with this type of patients at the time. And so we would have not been able to train from scratch on these data, the models. We also did the same for a different kind of patients, and in this case, they are premature. So these are kids that are born before due time, and so they are very different because, for example, in most cases, ribs are not there; they're not even formed. So there are significant differences in the imaging pattern. But you can essentially project once again the score we saw for COVID-19 patients to this population, and train models starting from, or actually fine-tune the models that were trained with the adults population for this type of population, getting very good results. In this case, the 77% accuracy and 78% of precision are provided at the video level. Okay, in this case, so pretty high. And what is important here to say is that also for the clinicians, actually here the agreement is higher because findings are somewhat easier to spot in this population, because you have actually the opposite. In an adult, you have a normal lung that eventually progresses into a disease state, while here you have a not properly developed lung that the clinicians try to push towards proper development. Right, we also I want to touch on data generation, because the idea is, what if instead, if you have few data, you try to generate the data, right, artificially? And so in this case, we tried to do it, apply generative adversarial networks to balance the data set, right? And then also for classifying. So basically what we did, we tried, in this case, we work with adults data. We were successful at generating data that showed significant value of diversity, say, from the data that were used for training those GANs. They were able to convince the clinicians. So basically, clinicians were not able to say this is real, this is not real. But when we tried then to use these networks to classify, then, well, they didn't really work. So I would say this study is not conclusive, in a sense that there are things that could be done probably to improve the classification performance. But at least what was interesting to see is that they are in fact capable to artificially generate data that can fool, let's say, a clinician. On data compression, this is also another interesting thing, especially for the implementation in existing systems, because sometimes the computational power on ultrasound scanners is not extremely high. So here the idea is, what if we compress the data in the sense that we reduce so we downsample the image size, right? So the de facto blurring, if you want the image, and as well as if we reduce the quantization levels, because you start with 8 bits, but maybe you can make it much less and still works. And the idea starts because I have myopia, so I don't see well now. But the idea is that, well, I can see the room now like this, and then even without glasses, I can still know who's who and how to walk around. So the idea is, what if we train the models on high quality data, but apply them to low quality data? Is it still working? Because that means that also data transferring or data storage is significantly improved. Okay, and well, essentially, intensity quantization factor, it doesn't matter. You can reduce by factor 8. So basically, having 1 bit to represent a pixel still works. Spatial downsampling does affect to a certain extent, but you can have a reduction of factor 4 and still get the frame level agreement, which is pretty high between the performance of the algorithm applied to the high quality data or to the spatial downsample one. Deployment. So with that being said, how do you actually deploy these systems? What we did for COVID is we made it available through a web application, and so people could just upload their data and get them assessed by the system, and they will get this semantic segmentation for every video. So also explaining why a certain score was given to the video, and then have also final report in showing the distribution of the scores. The problem is that it actually requires a lot of resources for cloud computing, because if you want this to be time efficient, and I'm talking about tens of seconds per video, if you want to have the semantic segmentation, you need a lot of GPU power. So that's kind of expensive. We also, though, deployed this into a commercial system, which is the one from Esaote. And so basically, the way it worked in the end is that the system was tailored to acquire and store the data as we wanted. And then the computation actually would happen online. So you would have to have the system connected as the computational resources on board would allow for the processing, but processing time would be too long, essentially. Right. So in conclusion, I would say standardization is important, but again, it cannot guarantee the absence of confounding factors, and that's really some strong limitation that it's there when you apply analysis to data acquired with current systems. Also remember that the ground truth we have here is not absolute because it's subjective. It has a level of subjectivity. And in general, I would say the achieved frame level labeling, the maximum you can expect to have is the range of 75%, while the prognostic level, which is the one which is actually clinically useful, goes in the 89% range. And in conclusion, the computational optimization is crucial for deployment, as we saw the other day. Finding fancy and complicated solution may not actually improve that much the final prognostic performance. So sometimes I would say it's not really needed. Right. So with this, I would just say, if you're interested, these are the new international guidelines and consensus on the use of lung ultrasound. So many of the things I discussed are present in this document. And well, I would like to thank all the collaborators that made all this work possible, as well as the funding bodies, and of course thank all the members of the group, because a lot of the work I showed here was actually made thanks to them. And well, that concludes the first. Thank you. Yeah. Thanks. Okay, so now we discuss what you can do essentially with current technology, with the limit of an imaging modality that is not designed for the lung. And as we saw, the problem is that the lung has air inside, and so that creates a huge reflection coefficient at the interface with intercostal tissue, and that conflicts with the assumption of standard imaging. So let's see instead how we could potentially use ultrasound in a different way to improve the specificity of lung ultrasound. Right. Okay, so here I would start by introducing a bit of concepts on physics of lung ultrasound artifacts, and then from there start to discuss how we can exploit what we know of the interaction between ultrasound waves and the lung to extract information, quantitative information that could be used essentially to differentiate between lung diseases. We'll also touch on lung mimicking femto studies because they are needed to prove the validity of these ideas and these features. Briefly touch on simulation studies, and then on the results of the first clinical studies on the application of these novel technology. Right. So what do we know? Vertical artifacts we know that they correlate with pathologies in which the volume originally occupied by air is now occupied by something that acoustically is similar to intercostal tissue. So it could be water, it could be blood, it could be scar tissue, right? So this opens doors to ultrasounds to propagate through, or channels, if you want. And that's why you see these type of artifacts in the images, right? So that means that after the pleural line in specific areas, you have penetration, essentially, of ultrasound wave through the lung surface. This can be defined, these areas, as acoustic trap. Okay, so this is the basic of the ideas I will describe today. So let's first see then what is an acoustic trap. So a definition of an acoustic trap is that it is a specific spatial distribution of media materials with significant differences in the speed of sound, such as, for example, air and soft tissue, right? So you go from 300 meters per second to 1,500 meters per second. And this specific spatial distribution is capable to trap an acoustic wave and behave like a secondary acoustic source, right? So this is an example of an acoustic trap, right? So you have, here you see a speed of sound map. Suppose you are imaging from the top to bottom. So first you have the intercostal tissue layers, speed of sound in 1,500 meters per second. And then at a certain point you encounter air. Now in this case, you just have a chunk of air. So that's not the case in the lung unless you have pneumothorax, but this is just for simplicity. Although you see there is sort of a hole, right? So there is a trap, essentially. So this specific spatial distribution of acoustic properties. And so, indeed, the trap is made by this specific spatial distribution. So that means that the wave has to enter the trap. So you have to come from an area, in this case of 1,500 meters per second, that is somewhat intruding into an area where speed of sound is, as for the lung, lower, 300 meters per second. Then you need this significant difference in the speed of sound values because the trap acoustic interface should be characterized by a high reflection coefficient. And that means that this part here, you see, so the edges of the trap need to be characterized by a high acoustic reflection coefficient. And that will make it behave like a secondary acoustic source. I have a simulation here. So you see this is a plane wave, it's propagating down, then it's entering the trap, and then there will be multiple reflection inside of this trap because the reflection coefficient at the edges is 1. So basically energy remains trapped there and keep on bouncing back and forward and keeps on sending signals back to the probe. So it's essentially like a secondary acoustic source. Now, of course, different sizes will translate in different scattering behavior, essentially in different periodicity of the backscattered ultrasound waves back to the probe. You see here just visually, for example, how these two different traps perform in terms of how they back reflect or backscatter the acoustic energy to the probe. So different shapes and sizes will actually activate, in essence, different resonance phenomena at specific frequencies. So you can think of matching your imaging frequency to the size of these traps to have a sort of indirect macroscopic histology of the lung surface through ultrasound spectroscopy. That's the basic idea. Right. So this, as I showed here, it's very simple. So you don't really have this chunk of air, but it's something more like this, right? So you have alveoli and their size and disposition may create this type of traps, right? And that's what we are interested in. Because when you move from a healthy to a diseased condition, in certain pathologies, not in all, what you have is indeed this reduction of the volume occupied by air, which you see here in this histology in white, and instead you have that the distance between them, it's filled with something that is, in this case in purple, acoustically like soft tissue, And so you have this spreading. And so what you like to know is not just the size of the air pockets, but also how are they separated from each other, as well as what's the content inside, right? Is it water? Is it blood? Is it scar tissue? And this, indeed, you see, when you have this progression from healthy to disease, you're actually creating these acoustic traps because you're opening access to ultrasound. And then the size of these channels is regulated by the distance between the alveoli by their sizes. And locally, when this happens, when the space is sufficiently large, you see a vertical artifact. Right. So if we study the signal that the machine translates into that artifact, probably we can have a characterization in size and eventually also characterize the material that is forming those traps. That's the idea. Now, very briefly, why should that work? Now, consider these black dots to be the alveoli, and they are a distance d from each other, and the wave is incoming, in this case, from your left, right? So say it's the alveolus at the far end, and then you have a first order scattering event that is generated. Then this wave travels back, and it's the other two alveoli, right? So this is a second order scattering event, and then the second order scattering fields will go back towards the alveolus that is further down over depth, which will scatter once again. And so there's going to be a distance in time t between the scattering events. And this distance t is regulated by the speed of sound, right, of the material in between these alveoli, and by the distance between the alveoli themselves. So what you can do is write down this t as a fraction between the distance and the speed of sound in the material. You can convert this t into a frequency by simply reverting it. And this is really nice because now we are linking frequency to a distance. So when the pulse length is longer than t, you basically have that multiple reflections will overlap one to another. And if they are overlapping in phase, they will be resonance. That will be showing resonance. So the intensity of the signal would rise. And so we think that's the cause, essentially, of these vertical artifacts. When this thing happens, we see vertical artifacts. That's why they're so much frequency dependent. So we are linking the distance to the frequency, meaning that if we sweep over frequencies and we observe the intensity of these signals, we are indirectly estimating the structure, the surface histology of the lung. Well, this is a simple graph that links basically a given frequency to a specific distance, and also to the length, the spatial length of an expected artifact as interpreted by clinical scanners. In millimeter, if you assume that you're counting up to the 60th reflection, consider the reflection coefficient after 60 reflection is still 0.55, so it's still humongous. So that means if you have a condition like this, the alveoli are too close to each other, there is no penetration, you won't see penetration through, so you have no signal to analyze. When you have a condition like this, where you have a small displacement, so it's not a really huge perturbation of the original disposition of the alveoli, you can think of mapping that as an histogram. So what are the possible distances that the wave could be traveling? And then it's easy if you use the formula we saw before and you link this distance to t and to frequency, you can map that to the frequency domain. Meaning larger distances would mean you'll see artifacts at lower frequencies and vice versa. Moreover, if you have a condition like this, where the acoustic trap is much more heterogeneous, well, you have an histogram of potential distances that is much broader, meaning you'll be activating this type of resonance over a broader range of frequencies. So if this is all true, what it means is we can indirectly and macroscopically characterize the alterations along the lung surface by means of this frequency characterization. And so we can, in fact, obtain the mean intra-alveolar distance as well as the distribution, right? Whether it's chaotic or more homogeneous, because, of course, the more chaos there is, the more frequencies will be activated. So the bandwidth over which we'll see this phenomena is broader. Moreover, what's interesting is that this would be a quantitative measure, right? It's not qualitative anymore. So this will make it much more reliable. And moreover, the idea is that this will improve the specificity of lung ultrasound, right? Because then we are really able to say, well, the alveolar structure is disordered and the content is scar tissue, well, that's fibrosis. Or it's only water and it's pretty ordered, well, then it's cardiopulmonary edema. Of course, we need to test. That's a nice idea, but does it work? Does it not? So we started with controllable model, and to me, the lung is just a cluster of air bubbles. That's the idea. The very basic model. So we started in 2016, and at the time collaborating with a Dutch company called Tide Microfluidics. They were making contrast agents. And I asked him, well, can you make contrast agents alveolar size, like 200 microns range? They said, well, we can try. So they tried, and it worked. And then we made, you see in the middle, this kind of cluster of bubbles we control the size of. So they're mimicking alveolar structures, and we can control the size of the alveoli. So we have a ground truth now. We started with two type of phantoms. So we have the big bubbles are, top of my head, 170 microns, and the others are 80 microns in size. So they're showing sort of a progression of a disease. Imaging, we don't do imaging in a standard fashion. We don't use a broadband pulse. We don't want to achieve a high spatial resolution. It's an artifact domain anyways, so we're not interested in spatial resolution. We are interested in frequency accuracy. So instead of these, we opt for a multi-frequency approach where we are in parallel generating data over orthogonal narrow bands, okay? So this is an example of an image from Phantom 1. So what you see here is essentially an horizontal artifact, so an A-line. So you see at the top is the interface with the bubble cloud, and then you see at twice the depth, there is the repetition. Remember, it's the bouncing of the wave back and forth between the surface, the air surface, let's say, and the probe. Then, if we switch the multi-frequency modality, what's interesting is that instead we see here also some artifacts which we couldn't see before. You see, at 4 megahertz, for example. That's very interesting. So first of all, we are sensitive, more sensitive than a broadband excitation because we are more specific in frequency. In fact, this size 180 micron is already pathological. While with the standard imaging, you wouldn't see anything. You would say, well, this is fine. And moreover, we can pinpoint that to a 4 megahertz. Then you switch to the smaller bubbles. We see then also with standard ultrasound vertical artifacts that appear, and that's interesting, and it's compatible with clinical findings. But then again, it means we'll be seeing the artifacts only pretty late in the reduction of alveolar size reduction. And when you switch to the multi-frequency mode, you see now that the artifact is at 6 megahertz. So small bubbles, higher frequencies, large bubbles, small frequencies. When you test it over many different phantoms, you see that it holds. And so we are able with these phantoms to recreate these artifacts. These vertical artifacts are severely frequency dependent, meaning you change the probe, you change the frequency, you can see completely different things. So you cannot just image with a single frequency. You have to sweep if you want to understand where this type of resonance is happening. And moreover, this characterization is able to differentiate the two conditions. So that's very useful. For example, if you think of grading, you want to see how far you are in the reduction of the alveolar size. We actually think it's not the bubble size, but it's, you see, when big bubbles are close together, the trap is bigger than with small bubbles are close together. And that's what we are seeing. So we are characterizing not the bubble size, it's not the resonance of the bubbles, it's the resonance of these traps. Okay, so that makes sense. Larger bubbles, larger traps, lower frequencies. In this case, though, the problem is that we don't have control on the disposition of the bubbles. So we have control on their size, but they're all the same size, and we don't have control on the actual disposition. Though we still repeated the same kind of study, making more phantoms and testing a huge amount of parameters to see if this would be potentially biasing this analysis. Okay, so how many elements, for example, is your active aperture using? How do you change the focal point? Because you remember, all these things were confounding factors before, right? While here, what's nice to see, so these are examples of images from these structures, so you can clearly see how the appearance changes over frequency. And when you quantify this by means of this parameter, which we called total intensity, meaning you have to essentially process the signal after the pleural line, and you do that by computing these parameter. You can compute this for the different frequencies and really have a frequency trend. And you see this is a nice bell shape. This is resonance. And you see what is nice is that this shape doesn't change when you change element, and also doesn't really change when you change the focal point. The appearance changes, yes, the frequency content doesn't. So it makes it very robust, much more robust than other things. It doesn't depend also on lateral resolution. That's very interesting. So again, that makes it much less affected by the fact you're using different probes. And so different sizes, for example, of the active aperture that may shape different beams. And then, we want to do something also a bit beyond that, because the argument from clinicians was, yeah, but the lungs are not, made of bubbles of the same size. They're more like this, right? You see here the histology and kind of a drawing. So they're like, I would like to have something like this. Yeah, so we made them happy. This is an actual microscopic image of a polydispersed population of contrast agents. And you see, it's interesting here. Different sizes of bubbles, you see the heterogeneity of the traps. The size is much different, right? And then we said, okay, then we want to make something else as well to compare. So we make instead a monodispersed bubble population. They're smaller, and you see the size of the traps is much more coherent. And we expect this to show different behavior, in the sense that the bandwidth over which we will see this resonance phenomena is larger for the polydispersed case. And so again, we created the phantoms. We're now getting quite skilled at that. So we really make like coins, really nice, really neat. Really like this. This collaboration with the Dutch company Solstice. And here, in this case, we could explore a very broad frequency range from 3 to 12 megahertz, because these are gelatin phantoms, so very low attenuation. So we can really go broad without fear of having strong absorption at the high frequencies. And indeed, the bandwidth does correlate with the airspace's distribution. So we have something that correlates with the size. We have something that correlates with the distribution. That's very nice. And moreover, as I said, this frequency is in fact the most impactful parameter. You see how much it does affect the total intensity, while changing focal point or the element size does really not impact as much. So it makes it a very robust parameter. We also wanted to study something more, and specifically we want to study the impact of the ensonification angle, because you go for convex probe, of course, you don't ensonify the pleura with the same angle, and moreover, the pleura is not always flat. So you want to see if that is impacting on your parameter estimation. We did this with a commercial phantom. So that means including attenuation, intercostal tissue layers. It's a bit more complex in that sense. We studied different parameters, including the center frequency, the bandwidth, of course, focal point position, and angle of incidence from -30 to 30 degrees. And so it comes out that the angle does impact a bit more. So a reason more to go with linear probes rather than convex if you want to image the lung, but still not as much as the frequency. You see the variation induced by frequency changes are from 0 to -60 dB in terms of the parameter we're studying, while you have a bias of, say, maximum 10 dB for the angle. And those are the extreme angles. So you can say, for example, if you use a convex probe, you limit a bit the field of view, reducing the variation in the angle of incidence, or you go with linear probe. Right, we also did some numerical study because, as I said before, the problem here is that we cannot control the distance, right, between the air pockets. We just generate statistically varying distances that could be more heterogeneous, less heterogeneous, but we want to have at least a numerical proof of the fact that indeed it's resonance, what we're looking at. And here we did a study where we are really looking at small variations in this S prime, that is the distance between the alveoli, and these could be as small as 20 micron. And so we could do it really gradually, stepping it in small steps. And what we saw is indeed when the size of the channel or the trap matches the resonance, that's the moment in which we see the artifact coming, when we process this signal as a normal machine would do. So that's very, very interesting and confirms essentially the hypothesis. So with that in mind, the clinicians were like, yeah, but this is only, numerical studies, phantom studies, they're very nice, but does it work in clinical practice? And yeah, so we tried also to do that. We implemented this multi-frequency approach on ULOP, which is a programmable research platform. We used clinically commercial clinical probes, linear probe to start. And then we have this first study with Fondazione Toscana Gabriele Monasterio in Pisa. And then we took, standard ultrasound imaging data. And then we took with the ULAP, the multi-frequency ultrasound imaging data, recording the RF data because we were working on the RF data, so to avoid the potential bias introduced by signal processing pipelines that we don't really have access to. And so again, some visual example. This is patient 1. You see a vertical artifact. That's all you can say, basically, right? There is an artifact, and that's it. Then you switch the multi-frequency imaging on, and you see that's only 3 megahertz. So if you would have imaged this at 4, you would have said, no, there's nothing to say. 5, the same. 6, the same. 3 megahertz, there is something. So first of all, you don't miss it, and second of all, you know that it's there at 3 megahertz. So it means something in a quantitative way. Other one, yes, it's another patient. Yeah, it has still a vertical artifact. Well, you can start to discuss the appearance of it. It's longer. It's I don't know. It's the pleural line looks a bit more abrupt. But again, you're just qualitatively assessing these data. You switch to the multi-frequency mode, and then you see that the artifact is there at 6 megahertz only. So it's a different case than the one we've seen before, and you can quantify this difference. So here was a first just test where we showed indeed that different patients show artifacts at different frequencies. And these were shown over different bandwidths, sometimes over all the frequencies, sometimes over only one, like the patient 3 case. You see it's only 3 megahertz. So, okay, so now the clinician said, okay, you're right, it does depend on frequency. It's there only in patients, but what can we do with it? Is it useful or is it not? And then, step by step. So in this case, what we are doing is projecting the quantitative assessment of these signals in a bidimensional domain. And in this case, alpha and beta are respectively, alpha is the bandwidth, and beta is the frequency at which the signal intensity is the strongest. So the resonance, if you want, frequency. And so you can put every patient in this kind of bidimensional domain. So these are fibrotic patients, okay? 13 fibrotic patients. These are patients with many different pathologies, because in this first study we had a population it was very old, and they had many different pathologies, sometimes coexisting pathologies. So the only pathology we could isolate was fibrosis. So we started there. Color code is just, in this case, it was the it was a normalized intensity across the different artifacts found in the patient. So this is basically how is the distribution of the artifacts characterization for every patient in this bidimensional plane. So for example, if you go here, that means that you see it's normalized, in fact. And so this patient will have a mean center frequency of 4.7, considering all the vertical artifacts, and a mean bandwidth between 3 and 3.5. If that answer. Yeah, no worries. Right. So then when you look at this, we also wanted to show, for example, that it doesn't make sense to count, right, the vertical artifacts. And you see here fibrosis in red and all the other diseases in blue, and you see it really, I mean, if you count them, and by the way, counting for us means quantifying this with this ETOT and saying it's a vertical artifact only if ETOT intensity is above a certain threshold. So we're not assessing it by eye. So it's quite reproducible, the counting done in this way. But still, you see, there's a large variability in the number of vertical artifacts. So you cannot really use it. It's not specific. While if you do this and you plot the patient in these bidimensional domain, you see that you can achieve a specificity and a sensitivity of 77 and 92% respectively. Then we can chip in also this, looking at the actual value of the intensities. And you see that the histogram for fibrosis is lower than for the other diseases. But that makes sense with the physics because it means you have scar tissue inside, which is high, which shows higher absorption than water or blood. So it makes sense with the physics, and then it improves specificity and sensitivity to 92%. This specificity and sensitivity should be considered in the capability of this system to apply differential diagnosis, fibrosis or anything else, in this small cohort of patients, though, so 26 in this case. Right. So as I said, only fibrosis characterization, this first study, few patients, 26, single center study, single probe, only linear probe, and not a very specific imaging protocol. So this was happening before COVID, right? So we were just saying to the clinician, scan where you see vertical artifact. Right, so then we move to the next clinical study. This is then a larger one with 100 patients from Humanitas Gavazzeni. In this case, we did the same study, but we used a standardized acquisition protocol, 12 areas. We used convex and linear probe because we wanted to show which one works best. And we extended the pathologies to cardiogenic pulmonary edema, to pneumonia and fibrosis. So here are, of course, the processing in the same. So with the linear probe, though, you go from 3 to 6 megahertz because you have a broader bandwidth to measure. With the convex probe, you go from 2 to 4. You extract the same parameters, maximum total intensity over frequency, then the native frequency, which is the frequency, say the resonance frequency that you measure, and then the bandwidth. You do that, and then again, you can project every patient into this bidimensional space, as well as look at the histograms of the intensities. So what's very nice, again, is that fibrosis show intensities that are significantly lower than the other diseases. Pneumonia and CP show close intensities, which makes sense, because in one case you have, say, water, and the other case you have blood. So still liquid, not a big difference in absorption between the two. And moreover, the differences are consistent between the two probes, right? So you see with linear probe, red and blue, red is lower than blue, and the same is true for the convex. So that was also interesting to see. And then if you use these to classify these pathologies, then you see that we reach accuracies in the 80% range, just with ultrasound. This is a larger data set, 66 patients. These are 2 centers. We used different probes, 3 different pathologies, And so these are the latest published results, although now we have results where we're not just doing differential diagnosis, but really multi-class, adding also COPD, in particular emphysema, and we're reaching a multi-class accuracy of 80% in this multi-class classification. So that's very, very promising, and we are also trying to, we actually succeeded, although I'm not presenting the results here, on making this fully automatic. So the segmentation as well as the feature extraction is completely automated. We are expanding these data to other centers. So with the Gemelli Hospital, which is a large academic hospital in Rome, and that gives us essentially the data with emphysema and additional fibrosis. What's very interesting is it seems that we also can distinguish inside the disease, for example, inside fibrosis, whether it is exacerbated pulmonary fibrosis or just pulmonary fibrosis, because we can basically see the reactivation of the inflammation. And that kind of makes sense because it means you have more liquid, right, than the other case. And then the other thing we're doing, we are expanding to neonatal, and in particular to premature neonatal patients. And that will be extremely interesting because it means that as for the phantom, we can expand to higher frequencies. You remember with the linear probe here, I was limited to 3, 4, 5 to 6 megahertz because of penetration problems. But with this type of population, intercostal tissue layer is going to be very thin, so we can really go much higher in frequency. And that, I think, is also the reason why the linear probe was working much better, because your bandwidth is larger. So you're doing this frequency characterization over a wider band, so you can extract more information. Right, so that brings me to the conclusion. I would say, I hope I convinced you that frequency characterization of ultrasound signals from the lung is effective at characterizing the alteration along the lung surface. So a series of confounding factors have been investigated and seem not to play a significant role in determining the frequency response. And that's important because if you want to bring it to the clinic, then you want to reduce as much as possible the effect of these confounding factors. Simulation studies are very helpful in understanding the mechanism, although of course they are simplified versions of what you have in reality. So that's why from there you step to controllable phantoms. That of course you lose a bit of control, but you gain in proximity to the real scenario. And then after that, of course, you have to move into the clinics and see if it works. But I think this process is very important because you try to understand. So you have an hypothesis that is based on the physics. You try to test it in a control experiment, and then once you see that it seems to be working like you think it is working, then you gradually move to the real scenario. And that's where these preliminary clinical studies show the potential of this technology to improve the specificity and, of course, also the reproducibility of the findings obtained from lung ultrasound. Again, if you're interested, please have a look at these new international guidelines and consensus on the use of lung ultrasound. And once again, I want to thank all the collaborators in the different countries, as well as the funding bodies from the different countries, and the guys of the group. And thank you very much for your attention. None.
So thanks a lot. Now we have two options. If you want to break for a coffee and a tea, then we can proceed on to the discussion section. Or if you want, we just keep going. What do you prefer?
With the questions. Up to you.
All right, so I'll take that as we continue.
Okay.
I actually have a couple of comments before we start with the
Absolutely.
questions. That are more like comments/remarks that maybe can help our audience understand a bit better a few things that are a bit new.
Mm-hmm.
So the first question is, I heard about the acoustic traps for the first time from you a few years ago. Who came up with this idea?
It's difficult. We call it, for example, the Fresnel roll, but apparently it was invented by Abdul, and I forgot the second name, like 1,000 years before. So if you ask me, I think it came from me, but
because this is, I think, a point that in your next slides I would suggest you highlight, because before you, lung ultrasound was an empirical thing. Like we see these aberrations, we think we correlate with something, we have no idea why. And now there's an explanation. This to me sounds like a big thing.
I agree.
It's one of those things that, for those who are not familiar with this thing, are a big step forward, because it brings lung ultrasound into the quantitative space, which is huge. And maybe you don't realize that because you're in this thing. But from outside, it's a huge, huge thing. And the other thing I would like you to elaborate a little bit on, because we had this discussion before, and to me was, again, one of those revealing moments, is the phantom stuff. Because many of you have worked with phantoms, I'm assuming. Lung ultrasound phantoms are a nightmare. But lung ultrasound phantoms are a nightmare on steroids.
Have fun,
because of reasons that now Libertario is going to tell us, because for me are still a bit mysterious. But it's really, really difficult to come up with an idea for a reliable ultrasound phantom. It's not like you didn't try.
No, we tried. We are still trying, by the way. So we haven't finished with that. There are many things that are missing. So where do I start? So, and here, because I wanted to be on time today and finish in 2 hours, I am. No, I think it's 1 hour. Oh, that's great. Then I can show you also other things. Did I go too fast? No? Okay, that's cool. So let me go. So here, for example, this is nice, right? But it's a commercial phantom. So they most likely have sponges below the pleural line. So they're only capable of creating these artifacts, but we have no clue on what's the size, the porous size. So we don't really can say too much, apart from the fact that it's generating or not the artifact. So for us, it was still useful because it has the ribs, it has a lot of features that are there in the clinic, and it was useful to see, for example, how changing the angle of incidence does influence the visualization of the pattern and so on. But again, it's quite limited. What we want is these kind of things, right? So we really want to have full control on the distribution of air in the volume. And that's a nightmare because you see here, so this looks nice, right? And so the way we do it is we, and you see this is the actual phantom. So you have actually a beaker, and then you pour inside mimicking gel, and it has to be liquid, and it has to be liquid temperature not exceeding 37 degrees, because otherwise it will dissolve the shells of the bubble. So you forget about knowing the size. So for us, we started with Dr. Hooker gelatin. You're probably familiar with that. You're Dutch, right? Yeah, so you know the Dr. Hooker. Yeah, so that's we started with that, and now we moved to Cameo as we are doing it in Italy. But yeah, and so you create sort of a cavity, and then you have to solidify it, and then after you have the cavity, you can inject the bubbles, and then after you inject the bubbles, you pour in some other liquid, and when you do that, what happens is that the bubbles, because of Archimedes' law, they just float to the surface. So they cluster all at the surface. So that's why we have control on the size, but we don't have the control on how they are relatively positioned one to another. So we can control the trap, the acoustic trap size, only by knowing, expecting how they will touch one another. And of course, so you see it more statistically speaking. So if you make homogeneous and small, then the traps will be homogeneous and small. If you make that heterogeneous, then the trap size is heterogeneous. So we don't really have control on the relative position. We cannot do, for example, test the same bubble size but different spacing. We can do only that in simulations. We have been trying, for example, to put charges, electric charges on the shells, because then by electrostatic force you can keep them separate. But we thought, and then we didn't even start because we understood that the distance we could keep was in the order of 1 micron, 2 micron, so it's useless. We haven't solved that yet. Let me see. Do you have? Do I have Wi-Fi here? Okay. These phantoms are great. We can test these heterogeneity. We can test different sizes. We are becoming quite good at making these phantoms. But then the other thing we want is really control on the distribution. So that's why we thought maybe we could 3D print, right? But then it's hard to 3D print air at these levels. So what we thought is that, well, we need a high reflection coefficient. So something that could be 3D printed at the micron scale with the high reflection coefficient is steel, like steel. So we made it phantoms of steel. So we made rods, and then we could go really well. You've seen this phantom, so we could go really like to 200 micron in size of the rod.
Yeah, the first time you showed them to me, and you said this is a lung phantom, I was like, metal rods. It's like, are you sure?
Yeah, so they're nice, and then in that case, you are mimicking this kind of thing. So if you have a rod and you take a cross section, right? That's the problem. Is that they were so good that the distance between them was really in the order of 100 microns, and we could not fit water inside. We couldn't, and we tried, but then the problem is that we were not sure whether the water was completely inside or there was partly there was air, so that also didn't really work. But I'm gonna try to show you this. No, this is not.
Because meanwhile, maybe I can comment also on another thing, because normal people like us would think, all right, I need to create a phantom of a lung. Why don't I use a lung? Right? Why don't I use like a pig lung? Why don't I use like a...
That's interesting. Well, maybe pig is okay, but the problem is that you won't be able to access the ground truth anyways, because the moment you image, the lung is in a way, and then if you take it out and you look at the histology, it's not the same way anymore. So while we wanted to have full control on the structure at the very same moment in which we are imaging it. For example, we also try to...
Also, these structures are at a size that is very hard to image.
Yeah. But
you cannot CT scan alveoli.
I was just about to say that you can use micro CT, right? So we try to scan those phantoms with micro CT. The problem is that they melt. Yeah, because the gel we use in order not to destroy the shell of the bubble has to be liquid at 37 degrees, so like body temperature. So when you put it in a CT scan, it warms it up and it melts. So so you would need something like agar-agar, but then if you go with agar-agar, let's leave it around 7 degrees Celsius, and that destroys the shell of the bubble. So another way we could, we were thinking maybe we could go for harder shells, like polymer shells, but that would also change a bit the thing, because then the shell is thicker, and then so reflection is different. And although it would be interesting because that could be simulating alveolar thickening that happens in inflammatory conditions. So these are other things we are thinking maybe of doing, but with these things, sometimes the time distance between the moment you think it and when you actually have it, it's could be a year, because it takes some time. So, but I wanted to show. Wanted to show you.
It's probably partly my fault because yesterday we went a bit long, so maybe I put some pressure on you and you didn't realize that.
Sorry, but that's good.
Yeah, no, that's good because I have a lot of questions.
That's good. That's good. I like questions. No. Yeah. So, so remember, I was saying what I showed you before is something that applies to pathologies where you have a decrease of air volume, right? So like fibrosis, edema, and pneumonia. But there are diseases where you have actually an increase of air, like emphysema or COPD in general. So where the alveoli becomes bigger. And that's a problem because then you cannot penetrate anymore. But then we thought, if that happens, something like this happens. So the roughness, the air roughness of the lung changes. So think of a sort of brile, and so we thought maybe we can still use this concept of the different frequencies, so going spectroscopy, because what is rough and what is smooth depends on your wavelength. Okay, so if you have a surface that has certain level of roughness in microns, but then you decrease the wavelength at a certain point, that roughness would not be perceived, and so the surface will be feeling as smooth. So we thought that's kind of cool. So we can use this multi-frequency approach to sense variations in roughness. And that's nice because in this case, so that's the idea. So we tested, of course, numerically. So you see here we have different roughness levels, and we can simulate pretty simple situations. So that makes also simulation done in a human time. We simulated muscle, and we simulated steel. We simulated steel because, as I said, we can print those structures. Those roughness structures we can print with that precision. So beyond the simulations, we actually did these phantoms, so where you see different roughness levels. Top of my head, from 600 micron to 200 micron, left to right. And so then we have a ground truth, and then we can check if with this very simple idea we can in fact characterize the roughness. And so these are the results. This is a comparison, for example, of the numerical simulations on top and the in vitro study at the bottom. And then you can see that the trends of the normalized intensity along the surface follows pretty much simulations, is coherent between the simulations and the experimental study. It's a very simple experimental study. It's a piece of steel, of controlled and periodic roughness. But it works. And so what you can do is essentially, in this case, we are showing when it does compare and when it doesn't. And what we think it's happening here is that we printed down to 200 microns, but we're kind of reaching the limit of the 3D printing machine for steel. So then the 200 is not really 200, it's a bit of more of a chaos. While when you move to the larger roughness level, then you see that it's nicely matching between 500 microns, for example, and 600 microns, also 450. But you see how at 200, 250, also 300, it's completely else from the simulations. And then you can come up with maps like this, where you're essentially displaying the total intensity as a function of the roughness diameter and the wavelength. And so you can get this very simple linear fit that you can use it when you analyze the data later on to say, okay, if the intensity is maximum at this particular wavelength, that means that the roughness level is this size. So this is something we are currently using, in fact, in this study I was telling you, to also differentiate between the pathologies I told you before, so cardiopulmonary edema, fibrosis, and pneumonia, and emphysema. That before would have been inaccessible to lung ultrasound because simply you don't really have artifacts. It will display the horizontal artifacts because there is no penetration. While in this case, we are trying to enable, the use of ultrasound also in these kind of pathologies. Yeah.
So before we continue with the discussion, were there any questions about these topics or any other
Anything,
questions so far?
curiosities?
Yes.
Thanks, Libertario. That was really, really interesting. Can you talk a little bit about the commercial transducers versus what you use in that study? So what we're getting now is these massively wideband commercial transducers that are using modern composite materials and other things.
Mm-hmm.
Is that fundamentally a design feature? I'm just wondering, can you force a commercial scanner to do what you've done in terms of?
I can.
Okay.
We are actually using commercial probes
Yep.
right now. It's so these studies are done with a linear array probe from Mesothel with bandwidth from say 3 to 12 megahertz.
So you can create the very narrow bandwidth
Yep.
just with a commercial transducer. Yep.
That's a different question. First you ask probe. I said yes.
Yep.
Probe, yes. For the scanner, you will have to ask the scanner manufacturer if they're interested in putting in AWGs. Then I think yes. We need, so like this scanner we have has AWGs, so we can really control the AWGs stands for arbitrary wave generator. Sorry. Yep. And so we can really shape the pulse the way we want. It's not that difficult to have narrow band pulses, to be honest. So it wouldn't be a major limitation. And I think most of scanners can do something like that. Maybe they don't do it as narrow as we do with these scanners, but it's not an hardware problem. If that's your question, it's not an hardware problem. We can actually benefit for a more tailored hardware in terms of the probe. For example, you see here we're doing linear and convex probe, right? And this was also an argument again with the clinicians, because they said, yeah, linear probe, I don't see the patterns that well because of attenuation. So for me, convex probe is better. While we were saying, no, I mean, the linear probe is better because you don't have this angle of incidence, confounding factor built in. You have a broader band, so you can see better, you can characterize better from the frequency standpoint the signals. And so then we thought, okay, we're gonna do it and see if you're right or if we are right. I mean, you never know. But then again, they prefer convex probe because visually it was giving them a better feedback. Well, here then we see that linear probe performs better. You have it here. So you see with the convex probe, you're stuck somewhat on the 73% accuracy, while when you focus on the same type of disease with the linear probe, it does improve. But what I would like to have actually is have also the 2 megahertz and maybe the 1 megahertz together with the 3, 4, 5, 6, and 7 potentially. I cannot do it right now. I cannot put this together because, yes, the protocol is the same, so I assume it's taken from the same point, but I don't really know. Actually, I know it's not. Let me put it this way. I think it's statistically impossible that you pick the same spot when you move away the linear probe and you take the convex and put it there. It's roughly the same area. So what I really would like to have is a probe with a linear footprint and a much broader band. And if somebody is happy to make it for us, they'll be happy to use it, let's say.
What about like the butterfly probe? Because that has a very wide bandwidth. Have you tried? I don't remember if you can actually control the frequency that well. It covers the whole body.
So in principle, that's a CMAT. right? So it should be broadband. CMOD though have some problems of inherent nonlinearity in the transmission. So you're transmitting at say 3 megahertz, but in reality you're transmitting also at other frequencies. And that for me is kind of a problem because I would like the probe to function as a linear system. But I never tried myself because the data we had for the butterfly were given to us by Boston University, and they collected the data within the project. So I never really tried to use it, but ideally, yeah, it's a linear footprint, broadband. So if we could control, and I don't know if we can and to what extent we can. We also that thing we are doing, for example, you see, we are jumping of 1 megahertz, but we don't really know if reducing it will be better, or jumping half a megahertz, for example. We started with this because we are displaying this also real time to the clinician. And then if you display too many images, then it's kind of a problem. It also slows down the interfrequency frame rate. So now we have a given frame rate dictated, of course, by the penetration depth, and we have to divide this over 4 frequencies because we transmit this simultaneously. So you have a linear aperture, and you transmit first 3, then 4, then 5, then 6, and then you switch to the other line, 3, 4, 5, 6, 3, 4, 5, 6. So that reduces the frame rate. Top of my head now, we are doing something around 7 hertz. If you look at a single frequency, okay. So that's also a problem. There's the question is how small do you want to go? And for now so the first study we only had linear probe. We didn't have the standardized protocol for which area we analyze. In this case, we added a convex probe. We added the standardized acquisition protocol. But well, there is still a lot of things we can do. We tested a bit the bandwidth over experimental studies with phantoms. It didn't seem to matter too much, like making it smaller than it is now. And that's kind of confirmed also from the clinical studies. So the specificity seems to be pretty good. So for now, we're staying with this, but in the future, especially if we move, for example, to plane wave, so that way we can really go. So these are all linear array beamforming, so that's why also the frame rate is relatively low. But if we go to plane wave, and which we are seeing that it doesn't really matter the beamforming, so most likely we can go to plane wave, then we can also increase the frequency sampling if you want. But these are all questions, so we haven't done that yet. And now we have this data that is becoming multi-center, so we like to keep this standard and grow, you know, the size of the data, the diversity, different pathologies. Yeah, but that's a good point.
Thank you.
Sorry, while I walk there, because there's another question from
Yep.
there. Sorry, Jack. I have a quick comment on this thing. So my intuitive understanding is that the way the aberration propagates through the frequency might tell you something about the size and the shape of the traps. Does
Yeah,
that make
size and
sense?
shape. Yeah,
So it's important to see how it actually propagates. So
at the different frequencies.
yeah, so maybe
Yes.
going between 3 and 4 with a finer beam might tell you.
Might be better, although. So if you look at this plot, it doesn't really look like we need more sampling. But this, again, it's from an experimental study. So again, we're kind of, it's a design choice, which we tested here. And then we said, okay, it looks like, you know, the shape, the bell shape seems to be properly sampled with the 1 megahertz frequency step. So probably sampling at the higher
Just look at this graph.
Yeah,
Like imagine you don't know what the phantom looks like.
yeah,
Look at this graph and I ask you,
yeah.
what do the structures look like? Because
Well, yeah, I can tell you something. I can see that you have this resonance that is basically between 5 and 6, and that links to these 80 microns. So in that case, I would say that is the mean value of your trap size distribution. And then when you look at the bandwidth, that's pretty small, the bandwidth here, so it looks pretty heterogeneous. So that would suggest your bubbles are all the same size. So I would say yes, but again, I don't have a definitive answer, because to do that I should try and really show that. Yeah, no, that's yeah.
just look at the graphs, for example, the plots, and I can tell you exactly what these structures look like. Then I can also diagnose basically what's inside.
Yeah, no, that's the idea. So we are, and again, we don't want to have in the end something that says this is the pathology, but we are aiming at saying the air pocket size is in this range, the spacing it's in this range, and it's heterogeneous or not heterogeneous, and the content between the air spaces is this. It's compatible with acoustic properties of water or of blood or of scar tissue.
But sorry, just a quick question.
Yeah.
This is where we're on while we're on this topic. So how deep does this information go actually? Because I'm assuming at some point.
You mean deep, like in the lung?
You're still scanning the surface, so I'm still looking at the surface of the lung, right? Because otherwise, I would expect something that is more speckled.
This is complicated to say. We have done some numerical study in this case where we changed the depth of the trap and tried to see whether that relates to some of the properties of the signals we receive. And so far, we concluded we cannot say how deep it is. Penetration depth is regulated by many things. Is regulated by the disease. So all the diseases we are talking about are diseases that reach the peripheral lung. So they will produce alteration of lung structure that are visible with ultrasound, all of them. So how deep we can see, that will depend also on the frequency we use. They are resonators. I don't know. I don't have an answer. So the fact that you are sensing the surface doesn't mean you cannot get information on the deeper structures. You, for example, take a structure that is hollow, and it does a sound, and then it's full, it does a different sound. So you don't necessarily need to reach it to feel what's inside. What's the accuracy at which this happens? I don't know. What are the frequencies that need to be used specifically? I don't know. I know I wrote a grant, so if they give me the money, I'll try to answer these questions. But yeah, I really don't know. I think again, one of the problems here with lung ultrasound is that people are stuck with the images, right? So they stuck with that, and they think they have to image things only. While I think, first of all, imaging is needed. You cannot just put a sensor there and acquire things, because later on you may realize you're looking at the ribs. And so you need imaging to navigate through the acquisition point. I'm absolutely sure about it. But then I imagine something like Doppler mode. So when you get to the point in which is, okay, this is the point where I want to measure, you kind of switch, and then the machine will do all the analysis that is needed and produce a quantitative assessment of the signals. And what we hope that's going to say give you, again, a macroscopic histology view, for sure, of the lung surface. Now, how deep is this surface? I don't know now. I really don't know. And to be honest, that's unknown. I mean, there are a lot of things that are written, and starting from just a few years ago, if you go in a med school book, it says ultrasound are useless for the lung. I think now we know it's not true, but now you see things that say there is no propagation. I don't know about it. The problem is that there is no study with ground truth. So how do you know? And as you see here, because you have these highly reflecting structures, the link between time and space is gone. It's gone. So you cannot say. You cannot say how deep was that signal coming from. You can try to estimate that based on some level of absorption, but these things are tricky because the way the multiple scattering interacts can modulate also the intensity much more strongly than absorption does. So it's complicated. It's fun, but it's complicated. Yeah. You're welcome.
Sorry, my question was perhaps a comment. I was just thinking about, as you were speaking about whether this can be translated to other areas. I know you're using sort of a frequency ray or frequency spectrum to analyze B mode characteristics, so where those artifacts appear in that frequency range. We've got a problem with other areas and other quantitative ultrasound areas where, for example, the liver, we are measuring things like attenuation, we're measuring things like backscatter coefficients. I'm just thinking, is there a place for this same approach? Not looking for, it's not about B mode characteristics, but it's more about, is there a place to measure a multi-frequency? Because histologically, the liver has very similar changes in different stages of disease, and they are reflection issues, they are attenuation issues with the level of fat and things. So I'm just wondering if you're aware of anyone else looking at this or has done it in other areas, but it wouldn't be looking at the B mode, it'd be looking at the raw data perhaps. Or
yeah, we are also looking at the raw data. I'm showing B mode because that's how we are showing it to the clinician, because again, the idea is to give them a way through which they can operate the acquisition of the data. So going back to the navigation, but we work on the RF data.
Because there's this sort of we're good to a point, but we can't narrow it down to be histologically specific. So there's a lot of overlap between some of these histological grades.
You mean in the liver?
In the liver, yeah. So I'm just thinking, is there a multi-frequency process that could help?
I'm sure there is. I'm not that knowledgeable on the liver. It's interesting because basically there you want to estimate fat content. Fat is highly absorbing and actually shows pretty different nonlinearity behavior compared to other tissues. So it's interesting. It's not easy to have a highly accurate estimates of absorption in reflection. Because then it's going to be mediated by many things, not just absorption. Ideally, you would like to do it in transmission, and that would be easier. But you cannot do it. So in this case, we tailored this approach because we wanted to search for resonance. So we really want to see. We are seeing these things really as bells, and we want to see which ones sound at certain frequencies. So the situation is different than the liver. But I can imagine that you can try definitely to apply this type of approach to liver in order to assess absorption, because in the end that's a frequency dependent behavior with fat showing higher absorption at higher frequencies. So if you want to estimate the slope, this is potentially where you could go. Yeah, but I haven't tried it myself.
Thank you. Another question from Jackie.
So now that you know that the different frequencies result in the artifacts at different levels, and the surface irregularities and heterogeneity of the surface creates different appearances, do you still feel like the 4 scoring system is the best, or do you foresee that it's going to increase to like a 5 score system, 0, 1, 2, 3, 4 in the future, or onwards?
So whether I will still use the previous qualitative assessments or not?
Yeah.
Difficult. I would leave that question to the clinicians, in a sense that I think so what I'm trying to show here, or at least that's the idea. I want to show the boundaries of certain methodologies, and so I want to say, okay, this is what you can do, and these are the limits. These are, this is how reliable the information you get from this. And then it's up to the clinician to decide. I can imagine that there could be situations in which even such a simple qualitative assessment is still useful if you don't have other means to assess the state of the lung. It could also be, especially because you can do it with more, say, cost-effective devices. So you could imagine even a GP that could have that and have a first look, and then if says, well, situation is so, maybe you go to the hospital, and then in the hospital you can have these more high-end systems. It could be something you deploy in more remote areas. I'm talking about, for example, Trento in the mountains, or you can have it on an helicopter.
Yeah.
So I think I don't necessarily think that one method should completely, kill the other. I think both probably can be there, and maybe you switch to this more sophisticated analysis only when you have already an hypothesis, or you want to say, I don't know if this is this pathology or this other pathology. Let's see what this device says. So yeah, I don't know. The only thing I'm convinced of is that the first approaches, they don't really give you specificity.
Yeah.
While these they can, and they can expand also to monitoring other pathologies like emphysema. So again, that depends on your need and your resources, I would say.
Yep. Thank you.
Welcome.
Any more questions? Actually, I have one discussion point. Actually, I have a long list of questions, but
Well, go ahead. I think
I'll ask them offline.
I've been fast. Yeah.
Because I would like to leave at least 10-15 minutes for coffee and a bit of networking.
Sure.
As they say. No, but my question was is more of a discussion point actually. When I look at these slides, at least in my way of doing things, the next big need would be simulating these things with increasing levels of complexity, approaching more and more. Unfortunately, as we all know, one of the big perks of ultrasound is that simulating it is basically impossible to the level at which you really need to get the right accuracy. But again, I'm just thinking out loud. I'm not sure how you simulated these situations, but if I were the guy having to work on these things, like let's say the Federico now, what I would do is I would micro CT scan, like
it's in the grant. Yeah.
A reasonably for the audience. What I would do is I would take a reasonably close to real situation.
histologies and then put them
Exactly.
in the
I would micro
simulation.
CT scan them and then perform a real world simulation
Yeah.
on using one of those super sophisticated new codes. I'm not sure which one I would go for right now, but maybe one of those codes that take into account everything.
They don't.
Yeah, I know.
No, that's a very good point. We always start with simple things like this because we want first to verify that the idea works in a very simple, controllable environment, and then we'll build on that. We have started to do those kind of simulations. So for this, I used Keywave. So it's okay.
Carolina? No,
No,
North.
Keywave, it's so it's Brad Treby. He's Australian. He's from Perth, and now is actually was
Freewave is the one from North Carolina.
I don't know, but they now started to use Keywave as well. So, but the thing is that here we have first of all the problem that everything is static. So just a solid and static distribution of acoustic properties, while the lung it's nothing but static. The other thing is that
let me stop you here.
Oh yeah.
My next question was exactly this, which
Okay.
is elastic properties of the materials that you're insonicating, because we know very well that when you have elastic properties involved, everything changes. So the way the walls, for example, react is going to be like a major thing. So how do you take that into account? To me is a bit, and to me it might be a first order effect, not just I don't know. Honestly.
No, you're absolutely correct on all the points. So what I actually would like to do is many things. So starting from these, say, binary acoustic property distributions and pretty simplistic. First of all, put in distributions that are still binary, but that come from histologies. So that we are working on at the moment, and then we can still simulate them. Then the problem is what we could do is add to that intercostal tissue, which you see now. Soft tissue is just a chunk of yellow material, but you have different layers, so you will have aberration through it, and you have to see that it's robust across different realization of these intercostal layers. And then the other thing is to add bubble dynamics. So there is so the code I worked on when I was doing my PhD was actually propagation through biological media, and then so I got to the point in which I was able to simulate nonlinear propagation, absorption, multiple scattering, and recently that code has been extended to bubble dynamics, but they can only do small bubbles like contrast agents, very small. The moment in which the bubble is large, it's a disaster basically. And we see it also with K waves, for example. We are having problem when we go from this to this, because then I'm going to go technical. So the derivative in acoustic properties distribution are so steep and so distributed that you start to have problem in convergence. While in this case, it's still doable. So there is on one hand a problem from the limit of current simulators, which doesn't mean we can cope with that and improve it. But it's difficult, and on the other hand, it's also computationally it's going to be very demanding if you want to simulate. And these are 2D simulations. I want in the end to have 3-dimensional volumetric simulations, eventually including the dynamics. So that's why I think I see it all parallel development. So we want to improve on numerical, and at the same time we want to improve on phantoms, and we want to improve on clinical. And we have to go, with all these directions together, and because they will help. And then one of those will be faster, and then the other one will slow down. But they're all 3 needed, I believe. but this is indeed very, very important. And right now, these simulations are I would say, pretty simplistic. Yeah.
And it's unfortunate because at the frequency, at the resonance level is exactly where you want to test these conditions, and it's also the most complex because that's when, and we know with microbubbles, you know, they start behaving really weirdly when you get around that resonance level.
They do. I have to say that the bubble size we are dealing with is too large for the frequencies we use for sensing. But going back to can you see inside, can you not? I don't know how much of the entire thing, structural vibration modes I'm activating, could be interesting or not interesting. So simulations will be very important for that. I could go much lower in frequencies without the need of the probe. I can go, I don't know. It could be that 500 hertz is relevant in this domain to a certain extent.
Is there anyone working on developing more sophisticated simulation software in the world? Because I think
Yes, but it's very complicated. So the only, I would say, very good try I know of is this from Delft, because they really managed to get three-dimensional simulations with contrast agent size bubbles, which actually works, and it's very, very nicely done. But it's complicated, and this kind of fundamental research, to be honest, doesn't really get funded that often. So that's the other problem, I believe. So that's why people target other types of research. But this is fundamental,
and it's been like this for 30 years now, maybe
Yeah.
40. So that's why this is an incredibly interesting research area. If someone is interested, I would love to work on this. The problem is there's been decades of people trying to improve, but we got to the level where, you got reasonably well to a certain level. Then if you want to make the extra very small step, it takes forever. It's
Yeah, because you need continuity. You need to invest and have time and people focused and dedicated on this. I think it's feasible. On one end, it's computational power. It's growing, so that helps. I remember when I was programming on parallel CPUs, not GPUs, and so I had to code in Fortran.
So that's my last question, which is everybody now is funding stuff that includes the word quantum. So quantum
language
computations for
I don't know.
quantum computations for ultrasound simulations might be. Is
a
anybody
good
into
word.
it?
I don't know.
Sorry, our quantum guy is not here today. He said he would come, Ajay. So we have a meeting with him actually in 10 minutes. If you want to join, we can have a chat with him.
Sure. I think any research in line with improving our capabilities to simulate ultrasound propagation in human tissue, it's welcome.
Any last questions? Otherwise, I would thank our speaker one last time with a nice round of applause. Thank you very much, Libertario. Once again, it was really inspiring.
Thank you.
And thanks on behalf of everyone that's going to watch these presentations in the next few months.
Yeah.
All right. Thanks a
you.
lot.
Thank you very much.
Everyone.
Have a great day. Era intelligibile o sono andato troppo veloce?
No, era molto buono.
Ok.
Però mi sono accorto che